and we'll wait for Senator. So let's call the Joint Subcommittee to study the mental health services in the Commonwealth in the 21st Century's Work Group number 3 to order. This is the Involuntary Commitment in Emergency Services group. I'm Delegate Patrick Hope, and welcome everyone here to testify about this particular issue related to mandatory outpatient treatment. Why don't I go ahead and turn it to you, Sarah, to call the roll? Why don't we start procedurally that way?
I think we need to have Michael. MJ's gonna
Michael, yeah.
Roll. MJ will call the roll.
I'm sorry, Michael. Mr. Jackson.
Delegate Rush.
Here.
Senator Mason. Senator Deeds. Delegate Hope.
I'm here.
Mr. Chairman, we have a quorum.
Thank you, Mr. Jackson. Just a couple things I wanted to read here. This meeting is live streamed and it's available to the public. So everyone who's participating, please keep your cameras on. Members should mute themselves at all times unless they are speaking. When speaking, presenters and members should identify themselves so the public knows who's exactly speaking. And if you would, I know we don't have a lot of members here, but for those that are here, please use the raise your hand function. And if you go into the center of the meeting, the Zoom webinar, and click on participants, there'll be all the participants will be up, and then there's a raise your hand button at the bottom. So if you would do that, that's how I will recognize you, with your raise your hand. And please, if you have questions, please direct them through the chair. I think that's the best way to proceed. And then we'll go from there. We have a couple of panelists that are going to present some of the work that the work group has been involved in here over the last few years at least. And then we're going to turn it to public comment. We do have some people that have signed up to speak publicly about this process. And so with that, we've got our first panelist that's here. This is the did a lion's share of the work group. We have Dr. Richard Bonney from the University of Virginia School of Law, who sort of headed this whole operation in this group, is here to testify. Lisa Daly with the Treatment Advocacy Center. Michael Razek, who's with the Alexandria Department of Community and Human Services. David Bice, who's a special justice. And Heather Zell from the University of Virginia School of Law are all here to testify as our first panelists. So with that, unless there's any questions, why don't we go ahead and turn it over to Dr. Bonney. Thank you so much for being here, Professor Bonney. You can go ahead and get started and share your screen.
Okay, let me make sure I know how to do that. So let's do that. Okay, can you see it? No, I just put share. I wonder why it's not, you can't see it.
We see your desktop if you can open the PowerPoint.
Oh, you're looking at the desktop. Oh, so if I moved, okay, I guess that was the issue. I've got two screens. So let me do this. Hold on, I'm going to take this. Did that do it? No.
No.
Dr. Bonney, you may want to close out, stop the screen sharing, and then you can work out and then reshare when it's time. Make sure you've got the PowerPoint presentation open and maximized.
While we're waiting for that, Heather, did you have a question, Ms. Zell?
Yes, I was just going to offer to run the slides if it's possible.
Yeah, you know something, Heather? Yeah, that's probably going to be the safest thing to do. Having these two monitors has completely screwed me up. So.
Okay. Yep. I'll pull them up. Okay.
There we go.
Good. Thank you.
Thank you, Professor Bonney.
All right, and you're going to be moving them, rather than me. Is that right?
Yes.
Okay. All right. Okay. So sorry for the delay. It was predictable, unfortunately. So let me just begin by thanking everyone for participating in this meeting. I want to acknowledge that Delegate Hope is the moving force behind this effort, and I certainly want to acknowledge that. And also Heidi Dix, I know, is here, and our partner in this effort has been the department. This has been, as I'll just mention, quite an intensive effort over almost 3 years now, I think, since Delegate Hope and I first, talked about it. Also, I want to take the occasion to acknowledge the tremendous contribution, of all the members of the work group. We were having some chit chat here before we started about it, and I know I felt that this was, I guess I've spent a career in one way or another, working with people to try to find consensus about issues, and certainly in the mental health area. And this was an extraordinary effort, I thought. It was opportunity to learn something every time that we met. Everybody was deeply engaged in the effort, and the consensus building effort, I thought, was just extraordinarily successful. And so it's been a great pleasure to participate in this, and hopefully, it'll bear some fruit for everybody. I would acknowledge specific members, but I think you're going to be hearing from many of the key players here, and then there are other people participating in the meeting today as well. So Heather, if you want to go to the next slide. I want to basically look backward. It's always a hazard for me to do this, but I want to look backward briefly a little bit about kind of the evolution of mandatory outpatient treatment in Virginia. And so just quickly, if you look at the bullets on this, going back to 1976 now, with regard to the statutes in Virginia, that was the year that Virginia basically rewrote the civil commitment statutes under the influence of what was kind of a nationwide due process reform of civil commitment statutes. The dangerousness criteria and so on that we're all familiar with are rooted in that period of time. Interestingly, in that statute, if somebody met the commitment criteria, the statute actually said, but only in a sentence or two, that if it would be the least restrictive alternative, a person could be committed to outpatient treatment. But there were no implementation procedures, at that time in the statute. Meanwhile, over the next couple of decades, mandatory outpatient treatment or assisted outpatient treatment, whatever it was called, began to be a kind of a major thrust of mental health reform activities over this period of time. As you can imagine, as state hospital census were shrinking, and efforts were made to beef up outpatient services and other supports in the community. So this was a distinct reform effort, as I said, that begins sometime in the 1980s. And part of that effort also was to develop attention to, as people were in the communities, what scientifically speaking and clinically speaking were indicators of risk of relapse, and then build outpatient criteria around that concept. But nothing was done in Virginia around this until 2008, when the commitment laws were overhauled, during that period, basically under the auspices of the Supreme Court. After the commission was established, the Virginia Tech tragedy occurred in April of 2007. And interestingly, I don't know how many people, in the room, so to speak, today are aware of this, but Cho had been had been evaluated for based on suicidal statements that he had made. And when the commitment hearing was held, he was committed, having met the criteria, but to outpatient treatment. And I was directed to go to the Cook Center at Virginia Tech. He never went, and one of the tragedies about, among many, in that situation was that there had been no implementation procedures in the statute with regard to mandatory outpatient treatment, and so nobody followed up with him, and that obviously was one of the vectors, really, about the tragedy. And so after that occurred, obviously the General Assembly was very interested in taking a look at civil commitment reform. And as a result, the commitment laws were overhauled in many respects, but one important part of it was to provide full implementation procedures for mandatory outpatient treatment. It was what we now call direct a mandatory outpatient treatment, just as it was the least restrictive alternative, in his case, and based on the original statute. The pre-auth, you're going to hear about these various forms of mandatory outpatient treatment as we go on, but pre-authorized step-down mandatory outpatient treatment was approved in 2009, basically allowing the special justice doing the initial commitment hearing to say, as part of this, we're anticipating that if the criteria are met at the time, that the person would be released to outpatient treatment or discharged to outpatient treatment. In 2011, modifications to pre-authorized treatment were mandatory outpatient treatment were adopted, mainly having to do with elongating the commitment period. And then a new form of step-down mandatory outpatient treatment based on a new hearing held in the hospital at the time of the recommended discharge. So that was in 2011. As you'll see in a slide I'll show later, there was not a lot of quick uptake for mandatory outpatient treatment. In fact, it was not expected actually to occur because one of the big discussions in 2007 was that how can we be making a large initiative with regard to outpatient treatment when we haven't built up, obviously, the community capacity to provide the outpatient services. And that was kind of the key question about whether this should be adopted or we should just wait until the services were available. And what the statute says is if the services aren't available, you can't order it, but so they have to be available. But it wasn't anticipated that it was going to be widely adopted until efforts to fill the gap in community services, were undertaken. There was a discernible increase in use of mandatory outpatient treatment in those areas of the state where there was a sufficiently robust services system, particularly in Northern Virginia and somewhat in Central Virginia, because of an effort to promote use of MOT by the department. And you'll see the data. There was a significant increase. It leveled off in about 2016. Now, this effort, the one that we're talking about now, began in 2018, as I said, at Delegate Hope's initiative. I think what was going on not only in Virginia, but nationally, was a greater interest in mandatory outpatient treatment. There were more data available about it, and so there are lessons, opportunities to be learned. Major national advocacy organizations, including the Treatment Advocacy Center, were trying to call attention to the need for greater use. In addition, obviously, STEP Virginia and the effort to begin to bolster community services played in anticipation of that, played a big role in this also. And so this initiative was adopted, was begun basically in 2008. Next slide. The charge of the work group is worth noting in light of what we're going to do today and some things that have not, that we probably won't get a chance to, but I do want to mention. So the charge, and this was now the charge document that was eventually drafted in conjunction with the department, was to invite participation by a broad array of stakeholders to consider revisions of the mandatory outpatient treatment statute with the aim of facilitating programs that are effective, informed by best practices, and considerate of the wishes and needs of the MOT participants. Secondly, to identify key policy options for discussion by the work group, and then prepare a report evaluating those options and making recommendations. And the report that has been distributed to you, I think, carries out that charge. That is basically what we're going to focus on today, if I understand the time frame that we have here. Another important aspect of this that I do at least want to highlight is that part of the charge was to draft a revised statutory framework that would reorganize the provisions in the statute, which, as I've indicated to you, kind of grew like Topsy over time, to be more coherent, consistent, and understandable. And I want to emphasize that's not a criticism of the General Assembly. I mean, you can see how the statute evolved the way that it did, but it became increasingly difficult as efforts were made to implement mandatory outpatient treatment for people who are not judges or lawyers to understand what the statute was actually saying and allowing. And that obviously is very important, certainly for the service providers and the clinicians at all levels, and certainly at the CSB level, and also for the participants themselves and their families, who really, in this context, actually do want to read what the law says. And so it was a lot of confusion about how to interpret the statute, and it was not drafted, obviously, with having kind of lay readers in mind. So that was actually a major reason why there was complete consensus when we started this process that it was time actually to look at the statute again. I think we're probably not going to talk about the statutory framework, but the work group actually has worked on that also. Next. Okay, so just a very, very quick note. I've indicated this was a 3-year effort, and it is worth noting how it evolved. It was an exploratory work group initially convened at the request of Delegate Hope, and based on a conversation with Senator Deeds, that this was something, in light of all the things that I mentioned earlier about the time in history, that this was worth doing now, and we should, try to appoint a work group, which I did, to take a look, begin this process. There were some proposals that emerged out of that effort, but they were deferred in the 2019 session of the General Assembly, and then, as a result of the discussions that stimulated, however, it was clear that we needed to broaden the effort and appoint a much wider array of participants in the work group. That's when the contractual relationship between the department and the institute was developed, so that we also had some assistance, some staff assistance, both in terms of research and in developing the report. There was an interim report with preliminary recommendations in December of 2019, with a few recommendations, some of which are reiterated, all of which are reiterated in this report. But for reasons that we needn't go into now, it was deferred by the General Assembly in that year, in part because of possible fiscal implications that we had not looked at. Then further intensification of the effort with expansion of work group membership occurred in the spring of just as COVID-19 was developing. But the work group went intensively between March and June of 2020 in order to produce the final report that you have. And as I said, I just think it was a remarkable effort. I mean, with all the inhibitions and so on that we were dealing with, that produced this report, which when I read it again, I just thought to myself, this is a really, really wonderful job that the members of the committee did. And that's what we're going to present. I'm going to turn it over now to just focus on the main recommendations of that report substantively. But I do want to remind you that we also, after June, after that report was finished, the legal members of the work group spent many months drafting a statute, trying to reorganize the statute in a way that would respond to some of the many of the concerns that had been raised and would incorporate the substantive changes that we were recommending as well. That was circulated to the full work group as membership to get their input, and was then turned over to Delegate Hope, and he can say whatever he wants to about that effort. Next slide. So here is an indication of the work group members. The names of everyone, of course, is in the report. We can go on to the next slide. I think it's going to be what I described to you earlier, just in terms of the curve, in terms of the frequency with which MOT orders had been issued. A key thing to take note of is that 90% of all these orders have been basically issued by 11 of the 125 general district courts in the country, so that they are still fairly localized around those that have the resources of the locations where there's CSB that have the resources, to implement. Among localities, even though we've got these three different pathways, each primarily uses one of the pathways. So the diversity of pathways depends upon which jurisdiction that you're actually in. 70% of all the MOT orders are not step-down orders, but those that are connected with direct mandatory outpatient treatment, as in the original statute. I think all of this just reflects the continuing effort to beef up, of course, the outpatient services around the state. Next. So this is the four areas that you're now going to hear from my colleagues on the work group. And so I'm going to turn this over now to Lisa, and hopefully she'll unmute and take it over from here.
Hi, everyone. I am Lisa Daly. I am the Director of Advocacy at the Treatment Advocacy Center. We're a national nonprofit. We basically work almost exclusively on civil commitment laws, and kind of have done studies of the various states and what their practices are with respect to MOT, or as it's known in other states, AOT. And I'm going to walk you through what the different pathways for MOT are in Virginia, and kind of what our discussion was around what changes we wanted to propose and were ultimately part of the recommendations here. So Virginia has three different types of MOT. The first variety is the direct MOT. This is the one that is the most frequently used in Virginia, and it is essentially you go to a commitment hearing, the special justice hears the evidence, and the determination is made that a person meets the criteria for inpatient civil commitment, but it appears based upon the services that are available in the area and how the person is doing, that they could be served in the community under a court order. And so this is basically an opportunity for an individual to avoid being hospitalized on an inpatient basis, even though they do meet criteria, because they can receive services in the community. This is obviously something that we would encourage people to consider increasingly during COVID. It's an opportunity to keep people out of institutional settings and to prevent people from being hospitalized and taking up beds if that's not the level of care that's required. We discussed various things about the direct MOT version, but we essentially, did reiterate the position that this is a valuable pathway to MOT, and it remained one of the things that we recommended as being part of the statutory framework for outpatient civil commitment in Virginia. The second form of MOT, the second pathway, is what we called pre-authorized step-down MOT. And basically this would be an individual goes to a commitment hearing. They are found to meet the criteria for inpatient commitment, and it is found that inpatient commitment in the hospital is the appropriate setting for that individual, requiring stabilization, et cetera, that individual can then be ordered at the same time that they are admitted for inpatient commitment, inpatient hospitalization. If they meet the other criteria that are included in the statute, there can be a pre-authorization for a period of step-down MOT after discharge. The way that this currently operates in Virginia, which was a big subject of our discussion, is the person is admitted for hospitalization, and then when the determination is made that the person is ready for discharge, it's the physician that makes sort of redetermines whether or not the person appears to still be a good candidate for MOT, and then can make that determination and discharge to MOT. We discussed this quite a bit because there were some issues that arose with respect to whether or not that way of that procedure was desirable, which I will get to in a minute. But that's basically the way that that was intended to work, is that you would make that determination that the person is eligible for a period of MOT discharge after they're ready to leave the hospital, at the same time that you would make the determination that they meet criteria and will be going inpatient. And then the final version of MOT is basically, we were referring to this as new hearing step down MOT. So this is basically if it did not occur that an individual had that pre-authorization for a period of step down supervised commitment in the community following discharge, there was still an option for an individual, the physician, the hospital, the CSB, any entity with appropriate knowledge could then file a petition to have the determination made that that person would be an appropriate candidate for step down MOT at discharge. So those are the three ways that an individual could be put under an MOT order in the state of Virginia. And then we discussed various issues in the work group about what kinds of things should we consider recommending as changes. We did vote on the issue and determined that all three were methods that we wanted to continue to have available in Virginia. There were benefits to each of the three. So the vote was basically that we should retain each form, but there are some specific changes that were recommended to make it function better. Obviously, the legislative intent that was part of the different procedures, that the legislature added different types of MOT indicates a legislative intent that there be use of outpatient civil commitment. And then considering that there had been sort of a leveling off of the use of it, we examined what the different statutory barriers might be that we should consider recommending changes to in order to promote better and more widespread and more appropriate use of MOT in the state of Virginia. Among the things that were determined, apart from the fact that we wanted to retain each of the three pathways, is we looked at the importance of standardizing the criteria. If you go to the next slide, we looked at standardizing the criteria between the two step-down forms of MOT. And this is kind of where I had mentioned that there are basically two different procedures that were followed for whether or not an individual would be subject to an MOT order at discharge. There were two different processes that were followed, and there wasn't really a particular reason for that. It was mostly just because they were introduced at different times and had sort of developed their own protocol. And it was voted on by members that the appropriate thing would be to standardize the two forms so that the procedures were different, but the actual process, the only thing that would be different is when the determination would be made that the individual was eligible for and would be eligible for an MOT step down order. So what that basically involved was, standardizing the language so that it was clear that you were making the same determination at both times, and then removing the physician determination for discharge at the end. And there were two real reasons why we recommended that, and this is following quite a bit of discussion amongst the work group, and we did arrive at a consensus that it would be appropriate to remove that step of having the physician make that second determination because of the fact that physicians really didn't want that role, didn't really want to be in a position of making that legal determination. And then we also discussed, and it was agreed that it creates kind of a legal ambiguity to put a physician in a position of basically overturning a court order. And what does it mean if the person, if the physician didn't decide to follow the court order? What is the status of that court order? Is it still out there? It hasn't been rescinded. There's no process for removing it. So we basically all agreed that, or agreed by consensus, that the appropriate thing would be to standardize those two criteria and to make clear how the process would work, either for the initial pre-authorized version of MOT or the new hearing step down MOT would be basically the same, with the exception just being when the determination would be made and whether or not there was a separate process or a new petition that would be filed. We did determine that the look back period that was put in place would be retained. And what that means is essentially that you would, in determining whether or not a person is appropriate as a candidate for MOT, we have something called a look back period that's written into the Virginia statute that basically limits the amount of time that you can consider. So you don't want to be looking at hospitalizations or arrests or incidents that are too far in the past. You want to make sure that you're really looking at the individual as they are at the time of the hearing, and you're not looking back too remotely. And then the exclusion of incarceration and hospitalization periods is basically to ensure that the period of time that you're looking at in determining whether a person's an appropriate candidate for MOT after discharge is you're looking at how they do when they are in the community. So obviously an institutional structured setting such as incarceration or hospitalization isn't really a good indicator of how the person does in the community. So you exclude those periods and you look back over the 36 months that the individual was last in the community and see, were they able to adhere to treatment? If they didn't adhere to treatment, could they benefit from an MOT order at step down? And if so, then they would be an appropriate candidate. So those were all decisions that, we discussed and took up and were part of the recommendations that made it into the final report. Next slide, please. And then the final issue of discussion, and I'm going to turn this over to Mike Razak to discuss how this has been a barrier in the implementation of the MOT statute. But there's language that is in the Virginia statute that kind of requires that the individual both agree to abide by the terms of an order and be able to abide by the terms of an order. And this agreement language has been problematic in the use of the statute for a couple of different reasons. I mean, obviously, it's desirable for an individual to agree to receive treatment, but as far as potentially excluding people who may benefit from an MOT order if they are not able to agree to, or if they're not going to agree to, but would be appropriate candidates, it essentially, by requiring an individual to be in a position to agree to treatment, you sort of exclude individuals who may then be required to be inpatient because they're unable to take advantage of the outpatient option. And it's also, Virginia is a real outlier in that there is not really another state that includes this kind of language. It just kind of sort of is contradictory to the idea of a mandatory order that you would require there to be an agreement. And as a statutory matter that we found, special justices were polled on this issue, and it was basically their opinion that by including this language, it sort of created an accidental legal problem in that an individual who was eligible for an MOT order because they had agreed could then become ineligible by no longer agreeing. And there wasn't really a legal mechanism about what to do in that indication. There wasn't really a way, nothing built into the statute, and not really a good legal way to address what happens if a person has agreed to an order and then becomes unwilling to continue with it. So this is the consensus of the group was that the agreement language should be removed from the statute, and that this would remove a significant barrier that exists to the implementation of MOT in Virginia, which is consistent with what we'd heard from many of the practitioners who had attempted or would have liked to have used the statute, but found that it was difficult based on the way that it was written in order to carry out the legislative intent. And it was pretty clear that the legislative intent for the MOT statutes each part of it as it was added was that it was meant to be mandatory, and it was meant to be something that could be imposed regardless of whether or not an individual maintained agreement throughout the entire process. We did indicate in our consensus that it would be appropriate to require judicial finding that a person does have the ability to abide by the MOT order. And this is more or less an issue of whether or not a person has the capacity to follow the order, which of course makes sense because it wouldn't really be an appropriate order for someone who can't really make use of the order. And then one of the points that was brought up by one of our peer individuals who is on the work group is that we wanted to expressly include within the statute that the individual's crisis plan or advance directive should be considered by the judge and the CSB and should, if at all possible, be incorporated into the MOT treatment plan. Basically, just to have the individual have as much ability to be participating in the development of the order as possible. And with that, I will turn it over to Mike Razak to discuss a little bit about some of the issues that we discussed with respect to the work group for responding to noncompliance, which we basically chose to recode as non-adherence. And Mike can also comment a little bit about the agreement issue and where some of these barriers had come into play as a practitioner.
Mr. Razak, are you with us?
I was on mute. I'm sorry. Thank you. Thanks, Lisa. Thanks to everybody for having me and letting me speak. As Dr. Bonnie mentioned, I do work with the Alexandria Community Services Board, but coordinate frequently with other boards in the area. So like to think that I speak from their experience as well. Just to build a little bit before moving on to the next slide on the need for agreement. One of the barriers, at least with Alexandria, and I know other MOT coordinators face as well, is that agreement criterion, that we have somebody we know is great for it, and then, you know, it comes down to it, and because that agreement criteria is there, we can't move forward for it, and this person is then denied an opportunity and a service and a program that may well be the key to them kind of turning things around and changing that pattern of hospitalization and high utilization that may not need to be there if they have the extra support that the MOT offers. The judicial finding was then kind of a follow on from that, because if the person can't agree, we need to make sure that the person has the ability to abide by the MOT order. And then Lisa, I think, mentioned the advanced directive or crisis plan, which is obviously appropriate if somebody has one of those to incorporate in, because that is the idea really, you know, and what we try to do as coordinators is, you know, we're not just monitoring from afar. While we are not often the primary provider, we do try and engage with the people. And the idea is that the MOT, even though, yes, it's a court order, we want to make it as much of a partnership as possible. And then if somebody has advanced directives and crisis plan or just voiced concerns, typically the CSB is the one who is translating those concerns and those documents and those preferences into action via the providers or via the court. So it is important to have all of that in there. So if we can move then to the next slide, which is already on, great. Responding to noncompliance. So one of the big issues for the CSB, once that MOT is already there, is across the state, there's a huge variety, not only in whether or not MOT is utilized, but in what that utilization looks like on the CSB end. And part of that is due to, I think, the vagueness of the statute, and that kind of this responding to noncompliance really gets at that, and the wording of the statute. It's not really clear what the CSB has to do other than monitor and report noncompliance. But what does monitor mean? How then, on the flip side, if you are a patient or an individual receiving services under an MOT, how can you confirm, and how can the court confirm that the CSB is upholding its side of the order? Because the order is really not, it's a, you know, in Alexandria, one of our special justices kind of refers to it as a 360 order, right? It's not just that the special justice is ordering the individual to engage in treatment. The special justice is ordering the CSB to monitor that treatment, and in many cases provide that treatment. So where's the accountability on the CSB side? And that brings us really to that first section where the CSB needs to document and facilitate document efforts to facilitate compliance and attempts to communicate. And really that comes into question, I think. Obviously, most CSBs are going to be doing their standard documentation. Anytime I reach out to a client under MOT, whether I actually connect with them or not, there's a note going in the system that I did make that attempt. If I send them an effort to notify them by mail because phone efforts haven't been successful, I'm copying that into our system to document that it's there. I think where it comes into question, where it's even more important than it is on an ongoing basis, is when there is non-compliance. And we'll talk about the phrasing in a minute. That the CSBs really need to document, you know, okay, we think this person, it falls under that not compliant category. Let's say, you know, they've missed 2 appointments. They didn't provide an explanation why. Really making sure that documentation is clear, because that's something that, you know, when we request a review hearing, that needs to be available. We need to be able to say, you know, as opposed to me just going in and saying, yeah, I tried to call them, because that's not helpful. You're not getting anywhere there. And that doesn't really stand up to, you know, legal scrutiny. Me just saying I did something. There needs to be that documentation. Moving on, that only can be successful, that documentation, those attempts, and I think standardized as much as possible, is if there is some sort of statutory guidance on what material noncompliance means, or non-adherence. Right now it means nothing. It means material noncompliance. So across the board, you see a lot of variety in interpretation of that. I prefer personally to give an individual leeway, right? If they miss a single appointment, that's fine. Everybody gets a gimme, right? If they miss 2, they really need to have an explanation for it. You know, that point it's becoming a pattern, so I need to understand why. But there's no guidance around that, and there's no statutory definition of what noncompliance is. The work group, what we came up with, which you know, I certainly strongly agree with, is that the best, while still maintaining some flexibility for interpretation, which is important, defining it as really just a deviation from the treatment plan without a reasonable explanation, and that deviation is likely to lead to decompensation, right? If somebody doesn't go to therapy a couple of times, but they're still going to psychiatry and taking their meds, and there's no other indication of any sort of, you know, faltering clinically, you know, do you need to have a review hearing and say they're material non-compliant because they're not going to therapy? That's more an opportunity for a discussion and exploration and possibly amending the treatment plan rather than any sort of penalty for punitive review. And then we come down to really the language of noncompliance. When I was starting out with the city of Alexandria, my supervisor at the time, I wrote a note that said, you know, individuals non-compliant with medication. And she said, don't use the word compliant here, use the word adherent. And while this sounds like I made up that story just for this because the words are perfect, that actually happened. And since then, I haven't used the word compliance because what she made clear to me is compliance again, it goes back to that idea that while the MOT is an order, from the CSB standpoint, and I think for buy-in from the individual, we really want to make it feel more like a partnership. And when you use comply, you're really saying, you're complying with it. You're really doubling down on that idea that it's an order. And for the CSB, we want to be partners with the MOT because we are subject to that order as well, right? And so shifting to non-adherence, you can say, well, that's just semantics, whatever. But semantics make a difference. Our word choices do make a difference. And I think adherence is just it's less heavy and negative. Are you sticking to it or not? It doesn't carry with it the idea of severe consequences that I think compliance does. And it carries an idea of volition and involvement and choice that I think we want to foster, even though it is an order. I think there's a way to blend the fact that this is a court order, you have to do it, there are consequences with it not being this big beast with scary teeth. And I think small changes like this can affect that change that we want to see in the community, where as providers and monitors and coordinators, we're talking to the people about non-adherence instead of non-compliance. And again, bolstering that idea that the CSB is here to work with you, not watch you and punish you. So with that, I will pass it off for the next slide.
Good afternoon. I am David Bice. I'm a special justice for the city of Lynchburg, and I've been in that role for 28, 29 years. I'm honored to be a part of this group, and I'm very pleased to see that the legislature, and I thank you, Delegate Hope, as well as the other legislators, for taking a close look at this process. One of the points that the group adopted, or didn't adopt, but perhaps more recognized, is that the MOT process, the goal of it is not to impose on individuals certain tasks or conditions by which they need to live, but rather, in a broader sense, to create an environment for them to succeed absent continued involvement in the form of hospitalizations. And so, from that perspective, fiscally, if the MOTs become more broadly used, then the state should, if we only look at this from a financial standpoint, realize a significant amount of savings. But sticking to what we recommended, currently, the only manner by which an individual who's under an MOT may be brought back before the court is if the local community services board files a petition for review. Now, as has already been said, the areas of the state that have more resources are those areas where we see, for the most part, a greater use of the mandatory outpatient treatment orders. Hence, up in Fairfax, they have even gone to the point of initiating a process that may or may not be supported under the statute that is being called review hearings. However, there is a certain therapeutic, or there can be a certain therapeutic result from the use of review hearings that the group recognized or the status hearings, excuse me. Review hearings currently are hearings that are brought about under the statute primarily in instances where either the CSB is requesting an extension of the order, rescission of the order, or for non-compliance. The status hearings, and of course, we do not engage in them in Lynchburg. So I'm speaking primarily from reports from my colleague, Michael Razak, and others, seem to be focused more toward very short-term, every several weeks, maybe anyway, a shorter term re-examination of a person's progress under a mandatory outpatient treatment order, rather than waiting a long period such as 90 or 180 days. Now, currently, the only individual that is allowed to petition for a review hearing is the Community Services Board. And that carries with it problems in and of itself. I mean, we have two parties or more than two parties in any one of these hearings, and yet the statutory framework is only to allow the monitoring party, the Community Services Board, the ability to petition for whatever relief it seeks. What is recommended is that we allow the person who's under the MOT to be able to petition for an amendment of the order, that a treatment provider be allowed to do so, that the original petitioner be allowed to do so, or the healthcare agent identified in a person's advance directive. Now, there was an awful lot of discussion about who should be allowed to petition. And there were some fairly strong voices in favor of allowing family members. But it was thought by the group that the connection between an individual under an MOT and their family members may lead to an unhealthy dynamic where perhaps a family member was seeking to force certain results that weren't maybe necessarily in that individual's best interest. Now, there was one other suggestion, and here there was a bit of a split within the group, and that was whether to authorize special justices to initiate status hearings or review hearings. And perhaps I just come at it from my training, having served in the judiciary for the last 29 years. And that is that I just can't think of another instance where a judge initiates or is a petitioner in a legal proceeding, and a mandatory outpatient treatment order or review hearing or a status hearing would be tantamount to that. Just the same, the other argument, which I think bears consideration, is that if the special justice is holding status hearings, perhaps that is providing a certain degree of therapy or bringing about greater compliance on the part of the person under the order. I tend to still feel, just as I feel strongly that doctors should not be making judicial determinations. In this instance, I would say that it's probably not a great idea to ask a special justice to be taking the step of initiating a hearing. But I'm only one voice, and really the group as a whole worked beautifully together. And I think that this is one of the very few points where we had some divergence of opinion. So with that, on to the next.
So maybe I'll jump in here, Delegate Hope. I think what our thought is that we would stop here and have whatever discussion you want to have about the recommendations substantively that would involve any changes substantively in the law, and set aside getting into the nitty-gritty of the drafting issues. If there's time to talk about that, obviously we could do that later. But I think, you should pick up the baton at this point. The one thing I'll just add, because David left it pregnant, so to speak, the committee as a whole recommended that the judge be, if that particular justice were so inclined, to be able to schedule status hearings. But everyone agreed that putting the judge in the role essentially of initiating review hearings would not be a good idea.
Well, thank you, Professor Bonney, and thank you to everyone who testified. Let me open up the floor to see if any of the members have any questions for the panelists. I mean, I am sort of much more intimately familiar with the process, more disconnected this past year than in previous years, but I do appreciate the work that the work group put into the amount of time that you put into this, and I agree with you. I have read the report, and I think it is really good work, and so I think the emphasis here is consensus more than anything else. I do want to emphasize, though, that when we brought some different pieces of this in different bills in previous years, some concern was raised about the fiscal implications of this. And I want to see if anyone cares to comment on this, because I think what you are doing by clarifying the statute and making this much more usable, which was the intent of the General Assembly, by the way. But we can make mistakes as well too. Not to write it in a way. I mean, I think want everyone to be clear that this is a tool that's already in our code. It just doesn't seem to be a usable thing. I think that what you're recommending will, in fact, increase the amount of hearings that are going to be held, which I think is a good thing, because that's how you get to the bottom of it, to see if MOT is appropriate or not, and to see how the individual's doing as well too. But also on the other side of that is the experience of hospitalizations and avoiding hospitalizations. I don't have to remind everyone, we have a bed crisis in this state and this entire nation. And I want to be certain that we're using all the tools that we have at our disposal. So can anyone care to comment about both aspects of that related to the likelihood that we're going to see an increase, a spike in hearings in the judicial process, but on the other hand, looking at a systematic reduction in the number of people being in inpatient hospitalizations, which can be expensive? Does anyone want to, or any separate people, other people want to take that question? It's a big.
I think that, if I may, The whole idea behind MOT, or one of the ideas, is to reduce a person's repeat hospitalizations, right? Really the thrust of it, through monitoring of their engagement in existing or to be set up services. And with that, I don't anticipate, or would not anticipate, even with an increase in hearings, certainly because there are new types of hearings, and when you clarify code and make things easier to do, they get done, one hopes. But those hearings, in my experience, and David, maybe you can speak to this too, those hearings, it's not common that at an MOT hearing, an individual is hospitalized. We've never had it happen in my 4 or 5 years of doing them. I'm sure it does happen, but not at a, let's say, statistically significant level where you would see a dramatic increase in hospital bed utilization. These are people who are either already in the hospital because they were subject to a TDO, or are they and the CSB and their providers are really trying hard not to have them back in the hospital. Perhaps a review hearing has been called to prevent a hospitalization. Let's get in there before the judge. Let's tweak your plan. Let's make it work. So I don't see the increase in hearings, which undoubtedly will happen, leading to an increase in hospital bed utilization. If anything, I would argue it would reduce it.
Well, that's what I was arguing, is that MOT by its very nature would avoid hospitalizations.
Yeah.
So you would see a spike in the number of hearings.
Okay, yeah.
A offset inverse reduction, because that's the hope, in hospitalizations. And so there's on one hand, there's a cost increase, but then there should be a significant cost decrease. David, did you want to comment? I saw your hand is up.
Yes, Delegate Hope. I can only speak anecdotally or on the basis of the statistics that Professor Bonney put together a number of years ago. But with the rise of MOTs, you do see a drop in hospitalizations. And anecdotally, I will just say, as a special justice, and I have a very limited population that I'm viewing, but of the individuals that have come before me, I see a lot more success stories ending up at the tail end of an MOT, or for an individual that's been the subject of an MOT, as opposed to a hospitalization.
Thank you.
And if I could just
Please,
jump in real quick, I would indicate that there is actually quite a bit of data that supports a finding that there is a cost savings, a net cost savings for increased use of MOT. And it's there, while there are some increases in cost for the number of hearings that you may have, at least initially, it's important to keep in mind that this is a population of individuals who are generally already in the system and generally are high utilizers within the system. This is a better and more likely to succeed way of handling a population and providing better services in their own community within their support networks for that population. It does, there's quite a bit of data that would indicate that an individual who is enrolled in MOT is going to see fewer days in the hospital, decreased likelihood of being incarcerated, and overall cost savings for civil hospital beds that are available. Not only does that decrease costs and keep your census down, which I know is a concern in Virginia, it also ensures that there are beds available for people who actually need that level of care. I mean, if an individual is able to receive the services they need in the community, that's always going to be less expensive, and it's always going to be better for the individual, and they're going to be more likely to stabilize and succeed in the community if they're able to do that.
Yeah, very good point. Professor Bonney, did you want to get in?
Yeah, I just want to reemphasize the points that have been made, but maybe in a way give you a little tool maybe that you'll be able to use on this argument. So I think the literature just as Lisa said, is so clear that when properly implemented, mandatory outpatient treatment, despite the fact that you're increasing, obviously, the services being delivered to the person when in the community, does reduce the rehospitalization. That's its whole point. It has been proven going back to the time, in the 80s and 90s when this research was, first done, and hence the greater interest, over those many years. And so I think at that level, I think that can be documented, which of course it can't, is to take a particular cost, like, if we increase status hearings and give the judges explicit authority to do status hearings, that's going to cost, if we have this many increase in status hearings, it's going to cost us this amount of money. Show us exactly how it's going to, offset hospitalization and quantify that. We're just not in a position, to be able to do it in that particular way. What I would say in partial answer, well, we can quantify other things. Why can't you quantify this too? As I was thinking about what Mike said earlier and what David said earlier, I think one of the advantages of having status hearings, which we're paying the judges a little bit more to conduct those, conduct those hearings, is that it's a clinic. When carried out properly, it's clinically helpful, because having that interaction under those circumstances, rather than not having the interaction with the judge around the order, is it is likely to, just as I think Mike said, if you take advantage of that opportunity when you have it, it's like providing a service, right, to the person to make the mandatory outpatient process more efficient, right, and more successful, right. And so when's the last time that we said that you had to show that providing better service, under the mandatory outpatient treatment order, even though it might cost a little more, needs to be, you need to show me that providing that particular service is going to, reduce that particular service, right, reduce the risk of rehospitalization. We don't do that. And one way to think about what the interactions with during the status hearings, at least, should be understood to be more like a service that is going to reduce the likelihood of rehospitalization, and trying to quantify that in the kind of the way that we might, want to do for fiscal impact is not the right way to do it. We're already committed to providing successful mandatory outpatient treatment services.
That's right. That's right. Thank you for that. Ms. Wright from the Supreme Court, you had your hand raised, and I do want to hear your perspective. I know you're a member of the work group as well, too. Do you want to comment on this?
I do. Thank you. Yes. We were members, non-voting, just to provide information, and because we do, through the Mental Health Commitment Fund, special justices are paid. And so as we did last year, if a bill would be introduced that would now allow for status hearings, although I understand some special justices may be holding them, others feel they don't have the authority and therefore the need for the statutory change, we would, as we did before, indicate in a fiscal impact that if there are an increased number of hearings, there would be an increased cost to pay for that. But I just wanted to clarify. I mean, I also hear what is being said, and I didn't want it understood when we submit a fiscal impact that we're not hearing the other side of it. But I think that I don't know what the proper forum would be to kind of show that other side of it, right? That's not really something that we would go into detail on a fiscal impact about how that might be offset with improved outcomes and less hospitalization.
Yeah.
But nevertheless, we have a duty to provide that fiscal impact as a possibility, although what's problematic, I mean, it would be indeterminate probably, because we don't really know, because it would be optional, how many of those status hearings there would actually be.
No, thank you for saying that. I really do appreciate that. I really appreciate you being part of the work group, providing the support. I kind of sense that was why the bills were sent to appropriations. And I want to make sure that, at least in this forum and carrying this over to the General Assembly, if we do decide to pursue this policy, that we have a conversation about both sides of the offsets and the costs and just be realistic about both. And so I appreciate that as well. Are there any other questions from the members on the work group?
May I ask one, Mr. Chairman? It's Monty.
Senator Mason.
I'm fairly new. I'm new to the team, so I apologize if this is just a ridiculously simplistic question, but you said 11 of the 125 general district courts issued 90% of these, and it's less than 1%. It's an extremely small number. Is that because just the existence of a mental health docket, or the communities just don't have the resources to do these things? Can you help me with that part? Thanks, sir.
This is Christy Wright. And one of the things I just want to clarify is that most of these are heard by special justices and not the actual general district court judges. And so it is maybe grouped by the districts, but they are not in fact done by district court judges. So I will let others who are more informed about. My understanding, though, is that it's a matter of perhaps resources within the community, but there may be other reasons that others would be able to address as well.
So I'll just say a couple of words about this. I think we haven't got the time to go into real detail. We do have a lot of data that we could bring to bear on this, and can certainly look at it more to talk to you about it. I think that it is fair to say that over time, there have been varied reasons as to why there hasn't been an uptake of mandatory outpatient treatment in various parts of the state. And we have had qualitative interviewing with various, folks around the state during the 2-year, period of this study. And some of the researchers that we've had doing it, I think, could provide a little texture, for you about what that looks like in various type places around the state. I think, however, despite, the complexity of, the many jurisdictions that we have, that it is probably the case that there are two big factors. That one is the lack of resources for providing the kind of intensive outpatient treatment services that are needed. And it doesn't only need to be the CSBs. There's discussion in the report, but about private providers. But that obviously increases also the complexity of of monitoring and so on. That probably involves the CSB as well. So I think the funding of the public mental health services and the CSBs is clearly an issue, and it does obviously vary around the state, as you well know. So that is clearly a factor. It's been a factor all along. The only reason I want to add something else is the experience that was had with regard to that training activity that was, that I said was undertaken, however, a decade ago or whatever it was, where there were a few states that were the initial uptake on it, but it was new, and there weren't innovators, in various places around the state, and they didn't really have the experience of knowing exactly what to do. That training activity that was initiated at that point clearly had an impact almost overnight in recruiting a number of other jurisdictions that felt that they do have the resources. And in addition, the statute says if you haven't got the resources, don't make the order. So to the extent that there were arrangements that were made in those locations where the CSBs were willing to say, yes, that we can do this, and the judges then, also participated in this, it did have an impact. And my guess is that given things that have developed, again, we're in a recession now, so I'm not speaking about overnight, but over time, a training activity could clearly have an important impact. And there is a missed opportunity in terms of the well-being, the mental health and well-being of the population that as you well know, with the increase of emergencies on the one hand and hospitalization on the other. So I think when the money is available to actually put together a training activity, I think you will see a significant change, but it needs to have that kind of attention. Probably to increase this beyond. I mean, 1%, we can do a lot better than that. But obviously, we're investing in the resources. We can also invest in the training activity also. And so the report says something about that, but obviously that's going to take some time, obviously, given the financing issue.
I'll just add real quickly that it's also some of it relates to where the population centers are within the state. You know, I mean, like some of it is just, yeah, obviously there's going to be a lot in Northern Virginia because the population is dense.
Good point. Any other questions from the members? We probably need to move on to the next panel.
Thank you.
Thank you, Senator Mason. All right, so thank you to the first panelist. I really do appreciate your time, effort, and resources you put into this. So why don't we go ahead and move on to the next panel, which is invited stakeholder comments. For this, I have David Fitzgerald, who is a member of the Arlington Community Services Board, Kathy Harkey, she's the Executive Director of NAMI Virginia, and Anna Menendez, who's the Executive Director of Partner for Mental Health, and Eric Smith, and all had some participation in this process. So why don't I go ahead and go with David Fitzgerald first. Mr. Fitzgerald, welcome, and thank you. Appreciate you being here to present your testimony. Mr. Fitzgerald, are you here?
And Delegate Hope, I'm not sure I see Mr. Fitzgerald on the call at this time.
Okay, let's go to Ms. Harkey.
Afternoon. Thank you all for having me here. And I will say that I joined the work group late. I was a part of the work group expansion in the spring. And so as I've sat here and listened, I've been writing down comments that I wanted to add, but Michael, David, and Lisa and Dr. Bonnie have covered everything that I wrote down. So I guess one of the main things that I would like to contribute is just to say that the work group really did a great job in paying special attention into finding ways to engage participants in the MOT process, while they also worked with language that would remove any impediments. And so just kudos to everyone. The recommendations in the report are awesome. And I am pleased to see you, Delegate Hope, taking the lead. Senator Mason, it's just an honor to see y'all taking the lead in this initiative to make MOT usable and an excellent tool for us in the state of Virginia. You were speaking about the physical impact of this, and there may be some on the front end, but I do believe that that will be more than made up for on the back end. And as you know, we're working on census reduction in the state of Virginia now. So I think that these two things will go hand in hand to assist in that area as well. And that's about everything that I have to add. Everyone on the group has done such a wonderful job. So thank you. It's been an honor to be here with you all today.
Thank you. Thank you for your testimony. Really appreciate it. Then why don't we go next to Anna Menendez from Partner for Mental Health. Ms. Mendez?
Thank you, Delegate Hope.
I apologize, Ms. Mendez.
Thank you, Delegate Hope. Good afternoon. My name is Anna Mendez, and it is my privilege to be the Executive Director of Partner for Mental Health. Partner for Mental Health is a nonprofit organization funded through private philanthropy. We provide direct service and advocacy for people with mental illness and have served the greater Charlottesville area since 1947. I'm grateful to have the opportunity to serve on the work group charged with examining Virginia's system of mandatory outpatient treatment. At Partner for Mental Health, we believe that people with mental illness can and should live self-determined lives in their home communities. While it may initially seem counterintuitive, we believe that in certain circumstances, a well-designed system of mandatory outpatient treatment can be an important tool to facilitate life in the community. Please allow me to explain. Meeting criteria for involuntary inpatient hospitalization does not always mean that involuntary hospitalization is necessary. There are countless Virginians with serious mental illness who meet criteria for involuntary hospitalization that have support structures in place to allow them to safely remain in their home communities and avoid the trauma associated with hospitalization. Generally, this looks like an individual who is currently so overwhelmed by the symptoms of their disease that they cannot meet their basic human needs, but have friends and family willing and able to provide for them. Virginia's current system of mandatory outpatient treatment requires that the individual in distress I described both be willing and competent to accept the assistance their friends and family are eager and in some cases desperate to provide. Currently, if the individual lacks the willingness to accept the help her family can and wants to give, or if she has been found to lack the capacity to consent to such help, there is currently only one outcome for her: involuntary inpatient hospitalization. This is despite the fact that in this case, her family is eager to provide her with a safe and less restrictive environment in which to recover. As controversial as it may seem, removing the requirement that a person must be willing and able to consent to mandatory outpatient treatment when they would otherwise be subject to involuntary hospitalization will result in more people with mental illness being able to remain in their home communities. We must provide people with care in the least restrictive environment possible. Basic human decency and the Department of Justice require it. An unintended consequence of our current system that requires consent for mandatory outpatient treatment is that individuals who could safely remain in the community are being unnecessarily hospitalized. This is an assault on their civil liberties and is not an acceptable use of limited hospital resources. An additional reason I call upon you to improve Virginia's system of mandatory outpatient treatment is the knowledge that the current statute is so complicated and uninterpretable that more than half of Virginia's community services boards never utilize mandatory outpatient treatment. This means that in these localities that choose not to utilize it, individuals in distress who could safely remain in the community are never given options to consent to less restrictive environments. They are simply required to experience involuntary hospitalization. Whether or not a person is given the opportunity to receive care in a less restrictive environment is dependent upon their geography is an injustice that should enrage you. It certainly enrages me. My comments until this point have been limited to instances that our work group has described as direct mandatory outpatient treatment. In other words, circumstances in which the person does in this moment also meet criteria for involuntary inpatient hospitalization. I hope I have made it clear that requiring consent for mandatory outpatient treatment in such cases results in unnecessary hospitalizations and should be abolished, which is the recommendation of our full work group. At Partner for Mental Health, our view on mandatory outpatient treatment in circumstances in which the person does not currently meet commitment criteria differs. Mandatory outpatient treatment in these circumstances is referred to step down and can be triggered either by a new hearing or as part of an original commitment order. But in most step down scenarios, the person does not, in the present moment, meet commitment criteria. At Partner for Mental Health, we believe that until such a time as Virginia has an exceptionally well-functioning, easily accessible continuum of evidence-based anti-racist mental health care, requiring a person to participate in mandatory outpatient hospitalization is an inappropriate intrusion on the person's civil liberty. We have come to this conclusion as the result of witnessing community members experience involuntary hospitalization if they are lucky, or arrest and incarceration if they are unlucky, while they were voluntarily on commitment criteria differs. Mandatory outpatient treatment in these circumstances is referred to step down and can be triggered either by a new hearing or as part of an original commitment order. But in most step-down scenarios, the person does not, in the present moment, meet commitment criteria. A partner for mental health. Sorry, I just heard myself and I wasn't speaking. I think I was hearing feedback from someone else. At Partner for Mental Health, we believe that until such a time as Virginia has an exceptionally well-functioning, easily accessible continuum of evidence-based anti-racist mental health care, requiring a person to participate in mandatory outpatient treatment when they do not currently meet the criteria for involuntary hospitalization is an inappropriate intrusion on a person's civil liberty. We have come to this conclusion as the result of witnessing community members experience involuntary hospitalization if they're lucky, or arrest and incarceration if they are unlucky, while they were voluntarily on waiting lists for community-based psychiatry and PAC team services. When a person does not currently meet involuntary commitment criteria, it is not acceptable to require them to receive mandatory outpatient treatment over their objection when our system is not yet able to provide them voluntary care in a comprehensive and timely way. Thank you for your ongoing work to improve Virginia's mental health service system. Virginians with mental illness deserve to live in a state that is best able to support their right to live self-determined lives in their home communities. In some circumstances, when the only alternative is involuntary inpatient hospitalization, thoughtfully improving the structure of mandatory outpatient treatment will facilitate community living. However, we oppose the expansion of mandatory outpatient treatment as a de facto substitute for building an easily accessible, evidence-based continuum of voluntary community services. Thank you.
Thank you, Ms. Mendez. Appreciate it. Eric Smith.
Yes, sir. Thank you for having me here today as a guest, Delegate Hope. I'm honored and I'm thankful to have this opportunity for discussion with you and the others in this meeting today. I am so thankful, not just to be here at this event, but here alive, because mandatory outpatient treatment, MOT, also known as assisted outpatient treatment or AOT, saved my life. So let's talk about that. And together we can explore the importance of MOT as a program and the laws on which it is based. My name is Eric Smith. I'm 37 years old, and I am speaking to you from Texas, but not intending to speak as a Texan who thinks I might know what's best for the people of Virginia. I'm speaking as someone of the severe mental illness population who knows firsthand that MOT saved my life and does so for others who share similarities with me as part of the diagnosed population. Some general relevant background for this is that for psychiatrists who have seen me at my worst, I've been diagnosed with schizoaffective disorder. For psychiatrists who haven't seen me at my worst, I've been diagnosed with bipolar disorder. Many years went by with no suggestion of hospitalization or some form of mandatory treatment because I was functioning well enough that that option was just never on the table. I nor any of my doctors over the years, none of them thought that that was an option that should be on the table for me until I was hospitalized for the first time in my mid-20s. And that was around 2009, just as you're getting this timeline together as I'm speaking. I was discharged from the hospital for the third and final time near the beginning of 2012. And at that time, I entered into San Antonio's groundbreaking assisted outpatient treatment program for the third and final time, also sometimes referred to as mandatory outpatient treatment in Virginia. The purpose and goals, very simple. First off, it was one hearing per week. And that was eventually moved to a less frequency. And it was done that way until I was deemed ready to graduate out of the program. The purpose and goals, rather, was to evaluate my mental health. And for those who aren't practitioners or aren't seeing how this is done, I can give you just a very brief background on what that looks like. The professionals on my treatment team, judge, psychiatrist, social worker, attorney there to make sure that my rights and liberties aren't being violated. They would, be able to size me up fairly quickly at each of these hearings to find out, to confirm that I still no longer required hospitalization, to help decide whether or not I could move to less frequent court hearings, which, as I mentioned earlier, did happen, and prepared me for reintegration back into society without needing further mandatory involvement. The time between my second and third hospitalizations was only a matter of several weeks because my psych meds stopped working for me. But being that I was on an MOT order at this time while I was decompensating, it was easy for the judge and the psychiatrist to get me the inpatient care and stabilization I needed. And without MOT at that juncture, it's easy to see how I could have been sent to an ER or hospital, jail, to manage my decompensate and dangerous and problematic symptoms. In fact, one of the main go-tos I'm told by medical experts in an ER when someone like me shows up in a decompensated state is being pumped full of Haldol. And I can tell you that medicine and others like it don't have a history of working for me. So that would have been a waste of time, energy, money, and other resources spent not only by me, but by the hospital, by first responders, and by society trying to remedy my situation with things that have already been identified by the MOT team as not working. One thing I'd like to address today is the value of making an order 6 months to begin with, rather than a shorter period of time, such as 90 days, and it makes total sense to do this. Swartz et al. 1999, and I'm quoting here, says, individuals whose outpatient commitment order lasted 6 months or fewer, regardless of the intensity of services received, were as likely as those who received no outpatient commitment to return to the hospital, have multiple hospitalizations, and to have longer lengths of stays. My first mandatory outpatient treatment order went nearly for a full year, and the length of that order was appropriate for me at that time and necessary for me at that time, and also is appropriate and necessary for others who shared in those similar circumstances as I was experiencing. In contrast, my third and final MOT order was originally set for a year, but I was doing so well that the judge, doctor, and the rest of my treatment team decided that after a few months, it was no longer necessary for me to be on any sort of mandatory outpatient treatment order, and so they terminated it early. In short, 90 days is unlikely to be enough time to reach the desirable stated outcomes of what MOT is intending to accomplish. It could for a few outliers. I'm not saying it wouldn't, but I would expect that those are outliers, especially based on the research that I've been looking at. And for a variety of reasons, it makes far more logistical sense to set an order at 6 months and then allow the discretion of judges and doctors and treatment teams and the people who are involved to use their discretion to determine if it's no longer necessary at 90 days or at some other point. And this way, there won't be time unnecessarily spent on labor to extend orders beyond 90 days, especially since the data shows 90 days is not likely to be enough to accomplish the goals for the population served by MOT. A big part of these hearings was to ensure I was taking my medication as prescribed. And if I was taking my meds as prescribed, but decompensating, the team could keep an eye on that and weigh options if and when I was falling away from sanity. At the hearings, the judge, Judge Kazin is his name, would ask, Eric, are you taking your meds as prescribed? And I'd sit there across from the table from him and I would say, yes, Judge Kazin. And I have clear memories of sitting there wondering how he or anyone else could possibly know if that's true. Oh, they would know. If you or any of you have ever seen someone with SMI not on meds or on meds that aren't working, you understand that it can be pretty apparent when someone is not sane. So when I was asked by a judge during my hearings whether or not I was taking meds, looking back, it was probably more about if I was appearing to be sane to him and the rest of my treatment team than whether I said yes or no. Also important to note, I never felt an urge to lie to the judge or the rest of my treatment team because I knew they were there to help me. And I knew this was not a criminal court trying to levy the power of a criminal justice gavel to treat my illness. These were civil proceedings guided by evidence-based compassion and understanding that the criminal justice system cannot fix matters of illness, and it's not designed to do so. The way AOT saved my life could perhaps best be summarized as the symbiotic relationship between a judge, doctor, social worker, and the rest of my treatment team, and it completely changed my view of managing mental illness. I was in a wonderful treatment program, an MOT program, And those non-criminal proceedings and the caring treatment cognitively and behaviorally taught me to take ownership of my treatment to the point that mandatory involvement was no longer necessary. And my desire to voluntarily adhere to treatment became a driving force in my life, benefiting me with an opportunity to pursue my goals, my dreams, and benefiting society with me no longer draining resources from police, FBI, Secret Service, hospital emergency rooms, psych hospitals, and the list goes on, but you get the idea. And I thought I was going to make it through this for the first time without crying, but I didn't. So I'm sorry, 1 second.
Hey, take your time, Mr. Smith.
Thank you. On a related note, and with certainty, mandatory outpatient treatment is not an opinion. It's a paradigm supported by a growing body of literature and stories like mine. There would be more literature if there was more funding for things like this, but I'm sure you know, Delegate Hope and others here, that the funding for SMI is relatively incomparably scarce compared to others. So stories like mine have to help color it in.
Thank you, Mr. Smith. Thank you so much.
Thank you. I'm almost done, sir.
Okay. Oh, I'm sorry. Yeah, please.
So when I was in the abyss of my illness, I was a victim of my mind's torment every single day. So it's important to understand MOT is not just about preventing one person from harming another. It's also about freeing the diagnosed population from being held hostage by their own minds. For people who are swayed by money as a bottom line rather than by moral arguments of right and wrong, MOT is about spending tax dollars and funding on something that works instead of a bottomless pit of money unnecessarily wasted on repeat trips to ER, repeat police calls, and endless hours of police transportation for those diagnosed with SMI to jail, where we know mental illness isn't meaningfully addressed. Disability rights groups and civil rights groups and others who fight against having strong MOT programs and better access to psychiatric beds are fighting for my right as an individual diagnosed with SMI to be a victim of the demons that owned every part of who I was before a psych bed and a strong MOT program saved my life. Without mandatory outpatient treatment, I would at best be living under a bridge somewhere, consumed by mental illness, but more likely than not, I would probably be dead. This program, MOT, enabled me to regain my health, start a new life, a better life, once thought distant fantasy by me. And it took me from a path of delusion and danger to becoming an accomplished, habitual honors student who's now diligently preparing as a graduate student to help others as I have been helped. Mandatory outpatient treatment helped me finally experience and fall in love with reality, a tall order for anyone to achieve in 90 days or less. So the importance of changing that order to 6 months cannot be overstated. So I summarize it like this. I was diagnosed with bipolar disorder and schizoaffective disorder, dropped out of high school, got a GED, failed out of college in my second semester, became an addict to various drugs, both prescribed and illicit, and I was committed to a mental hospital. Then mandatory outpatient treatment comes along as the safety net. And despite being a high school dropout, once hooked on drugs and diagnosed with SMI, I graduated in the top 10% of my class, got glowing letters of recommendation from my professors, and I beat all of the odds stacked against me because MOT was there for me. Without MOT, we know what that trajectory looks like. It's a downward spiral that wouldn't have stopped until it put me 6 feet under, hopefully not taking anyone else along with me. And with your support today, it can save other lives and also better serve the people of Virginia. Thank you.
Thank you, Mr. Smith. Thank you very much for your testimony. I'm going to go back because I know Mr. Fitzgerald has joined us. Mr. Fitzgerald, thank you for being here. Welcome.
Hi, sorry about that. Can you hear me, Pat?
I can hear you great. Thank you.
It's hard to follow Eric. Eric's super moving testimony. I know where you are. I have a son that went through the same experience, and I can tell you I'm here to testify similarly, if not as powerfully, and that is because we went through many years of recidivism, of cycling through hospitalization, probably as many as 6 or 7, before my son was availed with the mandatory outpatient treatment order, the first of its kind up here in Arlington, Virginia. The special justice at the time looked at the statute and said he wasn't sure he would be able to actually give it to my son, since my son did not at the time agree to its plan. But he overrode that concern and he initiated the MOT, and it was the beginning of many, many years of decompensation that my son was able to experience. So I became a CSB commissioner following all these experiences, and I became an advocate for improved use of MOT as a clinical tool to be used when appropriate for the cohort that we're trying to address, which is people with serious mental illness who lack insight into their illness. So I think that kind of testimony from Eric is super powerful. But I just wanted to briefly say, here in Arlington, over the last 18 months, we went ahead and we hired an MOT coordinator. Her name is Dee Foreman. She's probably listening to this because we were able to convince management that MOT was probably a very useful clinical tool in the toolkit that are used by clinicians to treat serious mental illness on an outpatient basis. And Dee has gone ahead and instituted a careful process of using the tool where appropriate. And Arlington has gone from issuing 2 MOTs a year, and those were mostly assigned to it from other jurisdictions, to using dozens a year now, and with great success. We have categorized instances of fewer hospitalizations, less criminalization. And so anything that goes to improving the use of MOT, like clarity in the statute, things that allow for MOT to be issued to those who lack insight, and for the extension of 90 days to 180 days to be clinically appropriate. I'm all for, and appreciate the opportunity to speak. Thank you.
Thank you, Mr. Fitzgerald. Are there any questions for the second panelist? Anyone from the members? Okay, not seeing any. Why don't we go ahead and move on, and thank you to the panelists for being here to share your testimony, and thank you also for your participation in the work group as well. A lot of high marks from those who participated, so I really appreciate it. So why don't we move over to public comment? And I have 3 speakers that have signed up. James Kelly will be our first speaker, followed by Sophia McNicholas. Mr. Kelly, if we can have you come in.
We only have, Mr. Chair, Sophia McNicholas is here.
Okay.
The other 2 have fallen out.
Okay. Ms. McNicholas, welcome. Thank you for joining us. We look forward to hearing from you.
Great. So this is actually more of a question for the panel instead of a statement, but to what extent do members of this committee distinguish between mental health and behavioral health, and how does the committee's categorization of the 2 affect how they understand the scope of mandatory outpatient treatment? My other question is, given the effectiveness of MOT and stories such as Eric Smith's, why has the General Assembly allocated $5.9 million to expanding Virginia Center for Behavioral Rehabilitation, VCBR, which won't actually increase the number of available psychiatric beds, instead of funding MOT programs around the state?
Do you have any testimony, Ms. McNicholas?
No, I just had questions for the committee.
Good. Well, of course, anyone's willing to address those, they certainly can. Are there any questions for Ms. McNicholas? Thank you for being here, Ms. McNicholas. I really appreciate your testimony. Okay, so why don't we then go ahead and turn it back to the members of the work group. Is there any, and when I say members, I mean the Involuntary Commitment Emergency Services work group that we're in. Any questions? Anyone want to have any further discussion on it? I think according to Ms. Stanton, the process is that we would forward this to, after hearing all the testimony, we'll forward the report to the commission for further discussion. But is there any at this time that we all want to discuss? I mean, I'm certainly throughout this process, not unbiased at all. I think anything that we can do to first make what we currently have in the code more workable is a positive thing. And of course, anything that we can do to keep people out of avoid hospitalizations is also very important too. So I certainly wholeheartedly support what the product of the work group and what they've produced. But does any other member want to share any other thoughts? All right, well, let me turn it back over. Oh, I'm sorry, Senator Mason.
Well, Mr. Chairman, thank you. So I'm really interested in Dr. Bonnie's comments about the training exercise from a decade or so ago and what that would look like. I'd also be interested in the data that they have regarding, so we know there's certain communities out there that have no chance, right? They just don't have the resources or aren't even close. But there also got to be a lot of communities out there that with some stepped up training, that there are the resources there that we could target and try to approach and try to talk to more aggressively. Because I don't know what the right number is, but certainly less than 1% can't be it, right? And and you and I, the age-old problem that Ms. Wright says that OES is going to put a fiscal impact statement on anything we do, as they must, right? I mean, that is. But, the old conversation about balancing the cost savings on the backside, and we're wrestling with that in a number of places. But I hope that fiscal impact statement would at least speak to that as well. But of course, we know that's a part of a larger conversation that we have everywhere. So.
No, absolutely. And it's something that I've thought about for a number of years, the training aspect of it, because whatever we do here, we've got to make sure that the special justices out there, the CSBs, anyone who's involved in this, know about MOT and know about the changes in the statute and whatever. So I think that there's going to need to be some training on that end. And I've been thinking about, maybe this is the time, maybe not the year necessarily, but we got to put a budget amendment in for some training of special justices. And that's something that we need to work with the Supreme Court and other stakeholders to make sure that that's something that we can do that can be part of this. I'd hate for it to be something in the future, but at the same time, I think it's necessary that we make these statutory changes and figure out a way, if there's a way we can fund it in this year or subsequent years, or to do it in as inexpensive as a way as possible. Because there's going to have to be some training involved here. And so I don't know if anyone wants to comment on that.
I'll just mention that as part of the survey process, we surveyed all of the special justices to kind of ask what their thoughts were about, which parts of these statutes are difficult to understand. And one of the questions that we asked is, do you think there should be more training? Would you like to do more training? And it was as close to unanimous as we got, that they would like training and they do want to learn more about how the statute is meant to be applied and meet with their colleagues and figure that out. So it's definitely something that there is support for, at least among the special justices, that they want to learn more and I think that the change, if we pass a reform bill that significantly overhauls the statute, that's a great opportunity to provide training on the new statute.
If we were to do that, I don't know if it's Ms. Wright or any others, could you all help us with what the costs would be for some comprehensive training in this area?
Yeah, sure. And I mean, a lot of that would depend on, of course, what it would look like. I do want to mention, and David, was a part of it just last week. There was the conference for special justices. We do a yearly training on that, and it was held. But as I recall, and as I looked back through in preparation for the meeting, the recommendations regarding training were more than just a meeting for the special justices, but I believe there were talk of like multidisciplinary groups getting together, having different coordinators and that sort of thing. So I think it is looking more comprehensively. And of course, there would be costs probably associated for CSBs and others, but absolutely, we're happy to be a part of that conversation as far as our role in that. But like I said, my understanding from the recommendations is there was a broader perspective desired in the trainings.
Very good. That's good to hear. Any other questions from the members? Okay, so not seeing any. Thank you all for being here today. So our work group number 3 will stand adjourned. Thanks everyone and have a great afternoon. Bye-bye.
Thank you.